Hi, MNT1 students. Welcome back to the second part of this chapter on anemias. I was reviewing part one and I caught an error that I made when I referred to erythropoiesis as the destruction of red blood cells, and I need to correct that. That is not right. Erythropoiesis is the process of creating new red blood cells. So please correct that in your mind, and forgive me for not correcting the first video, but it literally took 6 hours to upload that from my computer to YouTube, and I'd kind of like to avoid doing that once again. So anyway, let's go on now. We've completed iron and some microcytic anemias. Let's take a look at those anemias that occur because we have large immature red blood cells. The megaloblastic anemias tend ultimately to be an issue with correct interpretation or alterations in DNA function within the bone marrow. The end result is that we are seeing large, immature red blood cells. 95% of the cases of megaloblastic anemia are going to come back to either a folate or a vitamin B12 deficiency. The other 5% is probably going to be some kind of a defect related to the metabolism or the chemical reactions that are tied into vitamin B12. Probably this will come about because of some kind of alteration or mutation, again, in our patient's DNA. So a megaloblastic anemia from folate deficiency is going to develop fairly quickly and can develop in a 2 to 4 month period. B12 is much slower and less obvious, and it may actually take several years before someone will show the obvious signs of a megaloblastic anemia related to B12 deficiency. So in terms of the etiology or what is really causing folate deficiency, megaloblastic anemia, I want to just refer you to the little insert. It's difficult for me to actually see this even in a full-size slide. But if you take a look, you're going to see terms like methylene tetrahydrofolic acid and 5-10 and methyl tetrahydrofolate. Methylcobalamin is really kind of another name for vitamin B12, cobalamin. And if you can walk your way through these chemical reactions, you're going to see that when the processes are not going as we would like them to go, we'll sometimes see other chemicals start to accumulate. And that may actually be the biomarker or the sign that we will look for. So yeah, is it possible that I will see an elevated homocysteine level and I'll go, what? That has nothing to do with folate and B12. But in reality, if you start to walk your way through some of these metabolic processes, you're going to see that sometimes the biomarker is not the direct consequence that you are looking for. So causes of megaloblastic anemia, and right now we're probably focusing a bit more on folate deficiencies. It just may be an inadequate intake, whether this is a poor diet or possibly alcoholism, which interferes with good nutrition at several different levels. Do we have another condition that is leading us to inadequate absorption? And here's where later on, as we look at GI diseases, we'll see that sometimes we cannot absorb nutrients as our bodies had intended. And there are also some medications that may interfere with the absorption of folate and B12. Once this is absorbed and it's inside the body, there are other places in the series of chemical reactions that we can see problems show up. Is there an enzyme deficiency that doesn't allow the chemical processes to proceed? Sometimes drugs will create these kinds of issues. And then also we know for folate that B12 and vitamin C deficiency can also keep us from adequately using our folate. We know that there are some very increased requirements because there's such rapid tissue growth and need for new cells and new DNA. And so we really look for folate during pregnancy and infancy. Is there a possibility that there is an increased excretion of folate going on? We may see this in B12 deficiency, some liver diseases, and then hemodialysis will pull folate out of the body. Is there another condition going on that is actually creating a rapid destruction of folate? Okay. As far as the actual pathophysiology and then helping us to diagnose a folate deficiency, in stage 1 of a folate deficiency, we will order a lab test that is looking at serum levels of folate. So are the serum levels low? The general cutoff point is that we will see less than 3 nanograms per milliliter of folate. In stage 2, we will actually do a lab test that will look at the amount of folate that is found in the red blood cell. So in stage 2, beyond the serum, I mean kind of the liquid portion of the blood, we'll actually look at the amount of folate that is found in the cell. And in that case, we will look at less than 160 nanograms per milliliter. Keep in mind that most folate is not stored in the bloodstream, but is actually stored within the liver. But it's a lot more intrusive to go in and do a needle biopsy or see what the condition of the liver cells are. So we're constantly kind of plagued and looking for some kind of biomarker that will tell me what is going on elsewhere in the body. And so in this case, we've identified, first of all, a drop in serum levels of folate, and then secondly, a drop of folate levels within the red blood cell. By stage 3, we will actually see some damage coming about to the normal metabolism or processing of folate. And we're going to see that DNA synthesis for new tissues is going to definitely be slowing down. There's another biomarker test that we can do by stage 3, and this is a deoxyuridine suppression test. So if you would see an order for this and you're going, well, what is this? So it's another biomarker, another indication that we're looking at a folate deficiency. Remember, to really treat these things, I have to understand what the cause is. I will actually see some abnormalities now that will show up in my white blood cells, and there will be some lines within the nucleus that a trained pathologist can take a look at and identify. And probably most markedly, the red blood cells themselves are large and they are abnormally oval shaped. So they're clearly not what we want to see for an effective red blood cell. By stage 4, we have the signs of the clinical anemia. We'll have an elevated mean corpuscular volume and very, very large immature red blood cells. The symptoms of the patient are fatigue, sore tongue, diarrhea, irritability, forgetfulness, a loss of appetite. If we pull out their tongue and look at it, it may be just abnormally shiny and slick looking. And then we also may see weight loss associated with this. So our medical management, because we really have identified now that this is a folate deficiency, is to give folate. And we will start with 1 milligram taken every day for 2 to 3 weeks. And after that, we'll probably go to a maintenance level of 50 to 100 micrograms. And if we are still suspecting issues with malabsorption, or we know that alcohol abuse is continuing, we'll go ahead with a daily dose of 500 to 1,000 micrograms. The symptoms will actually improve in as little as 24 to 48 hours after we start giving folate, and then the lab values will be markedly improved, but that will take at least a month for that to happen. Beyond the administration of folate, the medical nutrition therapy is to really push for at least 1 fresh, uncooked fruit or dark green vegetable every day. Remember how fragile folate is, and it is easily destroyed by heat. The RDA is 400 micrograms, and this goes up significantly, almost 1.5 times to 600 micrograms during pregnancy. Okay, let's go on to vitamin B12. So again, this is termed pernicious anemia, and we may have a lack of vitamin B12 coming into the diet, but this slide really reviews for us a bit about the rather complicated digestion, absorption, and then metabolism of vitamin B12. So remember that when you eat vitamin B12, it is quite bound to proteins that are found in your food. And to be released from the proteins in your food, we really want a fairly acidic stomach. A normal pH is quite acidic, 2.3. But if we have someone who is taking antacids for any variety of reasons, and we know even aging tends to raise the pH of the stomach or make the stomach less acid. So all of these things can interfere with this normal first step in digesting vitamin B12. The stomach also makes intrinsic factor, and B12 will leave the stomach bound to a salivary R binder protein, and then once it enters into the small intestine, it will be freed from the salivary protein, and it will then attach to the intrinsic factor. So remember, the intrinsic factor is made in the stomach, but it doesn't actually activate and do its job until later on in the small intestine. So the intrinsic factor B12 combination is carried to the ileum, and it's attached to the brush border of the epithelial cells there. At this point, calcium needs to be present, and a pH of greater than 6 is required for the intrinsic factor B12 complex to break. If the B12 is released, it then attaches itself to another carrier, a holotranscobalamin 2 and haptochlorin, and these compounds will then wind up delivering B12 to cells. B12 is one of the water-soluble vitamins, and excess is quite easily excreted in the urine. So what's causing our pathophysiology? We really look for a lack of intrinsic factor. So the stomach is just not functioning in a healthy way. Perhaps it's been diseased, perhaps a part of it has been surgically removed, or perhaps it's just responding to aging. We may see just a lack of vitamin B12 in the diet. Consider this especially for the vegan. Remember, B12 only naturally occurs in animal-based products, and then so much of digestion and absorption is interrupted with heavy alcohol consumption. Consider, do I have other GI disorders going on? Is the pancreas not functioning as effectively and thereby not creating the pancreatic enzymes that are normal? Are the enzymes that are being produced inadequate in amount, or have they somehow been altered by something like chemotherapy or a disease? And so they're no longer binding to the B12 at exactly the moment that they need to. Do we have an increased requirement for B12? That especially may happen in hyperthyroidism, and there again, we'll ultimately look for a way to correct the hyperthyroidism. Do we have increased excretion, which may happen in renal or liver disease, or do we have an increased destruction of vitamin B12, which may happen when someone is inadvertently taking some high doses of vitamin C? Let's take a look at the stages of deficiency of vitamin B12 and then possibly leading to pernicious anemia. In the first stage of deficiency, or stage 1, I don't have a lot of biomarkers or ways to indicate that this condition is actually really beginning. If I were to do a fairly unusual lab test, low TC2. Now, TC2 stands for transcobalamin, and transcobalamin 2 is one of the primary carrier proteins that binds to vitamin B12 in the bloodstream. If I were to look at the level of this particular protein carrier, I would see that it is less than 40 picograms per milliliter. In stage 2, there will be a second biomarker that will show up. So I would still, if I were to test, I would see low TC2, but I would also see another protein carrier that would be low, and that is a protein carrier called haptocorin, and I would find less than 50 picograms of that in a milliliter of blood. Now, I'm not quite sure why there isn't a third biomarker that comes in stage 2, but probably in practice, and what I've certainly seen a great deal at Frater, is the order of a lab test called MMA, or the level of methylmalonic acid. Methylmalonic acid is one of the end products of chemical reactions that require vitamin B12. And when I start to see MMA decrease, that is a sign that is very specific to vitamin B12. So oftentimes we'll see the signs already of an elevated level of megaloblastic cells, but to help us discern if we're looking at B12 or folate deficiencies, the MMA will be the lab test that is used to indicate that this in fact is vitamin B12. By stage 3, we'll start to see some very subtle neuropsychiatric damages. There is a role of B12 in protecting the myelin sheath. The myelin sheath, of course, surrounds and protects your nerves. So again, nerve damage, if I don't catch this condition early enough, is one of the things that I'm greatly concerned about. I will at this point see a decreased total iron binding capacity, low levels of haptocorin, and decreased red cell folate. By stage 4, the clinical damage will be much more pronounced. Yes, I'm going to see the abnormal biochemical markers. Here, the methylmalonic acid levels will come in as helping us diagnose. But by this time, I may see myelin damage that will be a permanent damage. There may be some kind of psychiatric, mental functioning kinds of changes there may be a bit of dementia that results from this. Numbness in the hands and feet, poor muscle coordination, osteoporosis, and heart disease will all flow from this deficiency if we reach stage 4. So when we've diagnosed pernicious anemia, the medical management is to actually inject the B12 directly into the bloodstream. So either intramuscular or subcutaneous injections of 100 micrograms once per week, or oral doses of 1,000 micrograms. Keeping in mind that this is really a megadose of B12, but we estimate that only 1% will be absorbed really by diffusion, not by the normal carrier methods of absorbing vitamin B12. Once we've corrected this initially, the problem will not go away, and so our individual will probably receive injections once a month of 100 micrograms. The improvement in symptoms will actually happen within hours of the injection, but keep in mind that with many vitamin deficiencies, if it's been allowed to go on for a long period of time, there may actually be permanent damage, and this would be the case with nerve function that we cannot improve. The medical nutrition therapy that should go along with this is a higher protein diet. Shoot for 1.5 grams per kilogram. A lot of green leafy vegetables, meat, eggs, and milk. Keep in mind that metformin, really our most commonly prescribed medication for type 2 diabetes, does actually decrease the absorption of vitamin B12, and then boosting calcium intake may actually help to facilitate a better vitamin B12 absorption also. Okay, a bit on some of the other kinds of anemias that we see. It may just be that someone who is malnourished, who is not receiving enough protein and energy, is going to develop an anemia. Remember that protein is obviously a building block for red blood cell production. Although we know that a smaller body is going to need fewer red blood cells, the fact that there's a decrease in red blood cell production means that we may see a hypochromic or a pale red blood cell, but it will appear normal sized. Also, because the diet is lacking protein and energy, it's certainly possible that the same diet is inadequate in iron, folate, and vitamin B12. We also do want to consider that copper plays a role in the mobilization of iron, or the utilization of iron. Even though the individual may be consuming adequate or normal amounts of iron, in a copper deficiency, it simply is not able to be utilized and carried to the parts of the body where it is needed. We see this, or we have seen this, occasionally and rather sadly when infants are fed cow's milk rather than special infant formulas or human breast milk. We see it in severe cases of malabsorption or abnormal GI function and anatomy. And then we've also seen it when individuals are completely IV fed or are fed parenteral nutrition and there is no copper in that solution. Another anemia, and again, keep in mind these are really quite rare compared to iron, B12, and folate related nutritional anemias. But there is an anemia that is termed sideroblastic anemia. In this case, we see immature red blood cells that are actually small and low in color. We will see high serum iron along with this, and we know that there is a defect in an enzyme, aminovolinic acid synthetase, and B6 is needed for this particular enzyme. There does tend to be a buildup of iron, and that is found in the red blood cells. This isn't a true B6 deficiency in the diet, but we will find that administering some significant doses of B6, between 50 to 200 milligrams of B6, which is 25 to 100 times the RDA. But somehow this kind of mass flooding of B6 overrides or fixes in part the enzyme defect, and so we will see that this anemia will actually respond. Hence it's B6 responsive anemia, even though the diet may be more than adequate in vitamin B6. There is also a hemolytic anemia that is said to be vitamin E responsive. You might remember that we saw this initially in very premature infants, and their red blood cells would actually break down in the presence of oxygen because they had not yet incorporated vitamin E into the membranes of their red blood cells. So a defect in the red blood cell membrane leading to the cell lysing or breaking down, a very short lifespan of red blood cells, and vitamin E in its role as kind of a major antioxidant protector of cell membranes. An injection of this, a delivery of vitamin E, tends to protect and correct from this particular kind of hemolytic anemia. A few comments on sickle cell disease. 1 in 500 African Americans has this condition, and because of an alteration in DNA, their red blood cells will become sickle shaped rather than kind of that nice concave jelly donut shape of a healthy red blood cell. Because the red blood cell doesn't have the appropriate shape, it doesn't carry oxygen appropriately, the sickle cell tends to be abnormally large and will accumulate in the smaller blood vessels and cause blood clots and pain, and block the flow of blood into body tissues. We do see all this breakdown of red blood cells. The red blood cells here die in 10 to 20 days, and they normally have a 120-day lifespan. So the bone marrow really has a hard time keeping up with red blood cell production. And ultimately, the treatment for this is going to be that, yes, we'll give blood transfusions to correct the most major side effect of this particular disease. So our symptoms are anemia, abdominal pain, the liver eventually becomes damaged or does not function well. We may see the liver blocked, and jaundice or yellowing will show up. Gallstones are fairly common, as eventually is renal dysfunction and kidney failure. So our medical management is going to be to give monthly blood transfusions. There are some medications. Hydroxyurea is helpful. Oxygen therapy is helpful. Whatever strategies will work with the pain relief that comes whenever there is a blockage in a blood vessel. There will probably be some tissue death and a lot of pain associated with that particular blockage. And then we may actually give supplemental zinc, because zinc will actually improve the red blood cells that are there, will help with their ability to bind to oxygen. The medical nutrition therapy is for a well-balanced, perhaps slightly higher calorie diet. Adequate protein or a little high on the protein side is preferred, but it is interesting that the vegetable version of protein is probably preferred over high intakes of meat and dairy. A diet that is high in folate, zinc, and copper, and we might consider supplemental A, C, D, E, calcium, and fiber. We do not give supplemental iron. Remember, iron may actually be building up because we can't produce red blood cells as quickly as we want to. Avoid alcohol, avoid supplemental no, avoid alcohol, and then low sodium may be helpful, as well as a nice consumption of 2 to 3 quarts of water per day. Okay, comment on sports anemia. This is something that happens actually fairly normally in the early stages of training as the body is adapting to this increased demand put on it by some pretty heavy exercise. Red blood cells are being destroyed rather quickly. Hemoglobin levels may fall. Serum iron and serum ferritin therefore change also. This is kind of a problem of blood volume and dilution. If iron levels are low, go ahead and focus on iron foods, but primarily a diet that is adequate in protein, and then avoid tea, coffee, antacids, hydrogen blockers, and tetracycline. Thalassemia is a rare genetically based, it's an inherited disorder, and it results in a defective hemoglobin synthesis. So we wind up with, again, a red blood cell that doesn't even begin to live its normal 120 days. This is a genetic issue that originated, at least primarily, through the Mediterranean regions of the world. The symptoms are an increase in plasma volume and enlarged spleen. And then the bone marrow will attempt to compensate by actually expanding beyond its normal confines within the bone. We will see some facial deformities in these folks. They have some bone issues and bone changes. Some oxidative damage may happen almost anywhere within the body because iron is accumulating. So heart, liver, and endocrine glands especially tend to be places where this iron will accumulate. The treatment is to give blood transfusions and to attempt to chelate out the excess iron with some medications. The diet is high protein, B vitamins, calcium, and adequate hydration. Again, this slide, this is a microcytic hypochromic anemia, but actually really rare. So this has been, boy, if this is an attempt to make it simple, I'm going to apologize. This is an incredibly complex area. And I think that for you at this moment in time, the idea that you can look at lab values, look up those lab values, and start to determine what kinds of anemias we are seeing. You'll look at the patient's conditions and you'll start to realize that, in fact, this kind of anemia is almost expected in this condition. And then you will check into whether some appropriate therapies or appropriate investigative lab values have actually been ordered so that the best treatment and the best therapy for your patient can be undertaken. As you work with these and you just get confident in identifying the conditions, I think you will, in many cases, be fascinated by the metabolism and find yourself going back into the textbooks for even more details that will start to make more sense. So again, very basic, just to start right now, looking at your patient's lab values and starting to identify what kind of anemia they are actually contending with. Okay, over and out from Polar Vortex 2019. See you soon.